Uh, Hello, good afternoon. I would like first to thank Professor Marcelin for the invitation to give this presentation on new drugs for HBV cure. As you know, we are entering a very exciting moment for the treatment of hepatitis B, as there are many emerging treatment targets for the cure of HBV infection. Regarding the different classes of antivirals, we have direct-acting antivirals that may act differently. The first categories of drugs target the pool of cccDNA with the aim of achieving a cure of the infection. These drugs are mainly in preclinical development. Many other drugs are targeting pre- and post-cccDNA targets to control viral replication and induce a very profound inhibition of viral replication. And they include entry inhibitors, drugs targeting viral RNAs, drugs targeting nucleocapsid assembly, and inhibitors of HBs antigen release, in addition to the nucleoside analogs that we all know and that are polymerase inhibitors. Beside direct-acting antivirals, we have boosters of innate immunity, mainly toll-like receptor agonists, whose effect is mainly to induce antiviral cytokines that may cure infected hepatocytes, but also cytokines that may lead to the stimulation of adaptive immune responses. There are other strategies that aim at directly targeting and stimulating adaptive immunity. They rely on checkpoint inhibitors, vaccine therapy, or even more complex therapies with the engineering of T cells to redirect them to specifically kill infected hepatocytes. There are other strategies, mainly based on vaccines approach, to stimulate B cell responses to induce viral neutralization. So you see that with all these type of different treatments, we have all the assets to evaluate combination therapies to increase the rate of HBV cure. You see here a summary table showing a list of drugs that are in clinical development. This list is obviously not exhaustive, but it shows that the field is very active and that many drugs have been evaluated in phase 1b and now phase 2 or 2a or 2b clinical trials. So this is really promising for the future. So now the main question when we have these different classes of drugs is how to combine them to achieve viral control and HBs antigen loss with a finite duration treatment. So as you've seen, we have inhibitors of viral replications, drugs that can reduce antigen expression and antigen load in serum, and we have immune stimulators that can either invigorate immune responses or stimulate HBV-specific B or T cells. So there are different concepts that are being evaluated. The first one is whether a profound inhibition of viral replication can induce a decrease in the pool of cccDNA in the liver that would lead to a clearance of HBs antigen. So one approach is a combination of nucleoside analogs and capsid assembly modulators. So there are many capsid assembly modulators in clinical trials, and I will show you just one example of the Vebicorvir studies in association with Entecavir for 72 weeks, which showed a very profound inhibition of viral DNA in serum, a decline in HBV RNA in serum, which is consistent with the mode of action of the capsid assembly modulator. And when you look at the change from baseline for individual patients of different biomarkers, you see that in most patients you can see a decrease in pregenomic RNA, HBC-related antigen, HBe antigen, and HBs antigen, which is promising. So at this stage, it was decided that in some patients having the best response, to stop therapy and observe patients after treatment cessation. And despite a very good response after 72 weeks of treatment, the majority of patients relapsed after treatment cessation. So the message may be that we may need more potent capsid assembly modulators that would affect more profoundly cccDNA, or that we need to extend the treatment duration, or that we need to combine with other classes of drugs. So in terms of other direct-acting antivirals, there are drugs that decrease antigen expression mainly by targeting viral RNAs, such as siRNA and antisense oligonucleotides that have been evaluated in combination with nucleoside analogs. These compounds have shown very interesting results in terms of decrease of HBs antigen in serum. So the next question was whether we can combine three different classes of direct-acting antivirals, nucleoside analogs, a capsid assembly modulator, and an siRNA to achieve a very profound inhibition of viral replication and a decreased antigen expression. And this was done in a very nice proof of concept study. It was presented a little bit more than a year ago at ASLD. And that combination of nuc and CAM and siRNA showed a very nice decline in HBV DNA. And interestingly, most of the patients achieved more than a log decline in HBs antigen in serum after 100 days. And the HBs reduction was similar in e antigen positive and e antigen negative patients. So this type of combination is really promising, and we are really eager to see results of longer term administration to see if we can achieve a functional cure. Now, in terms of different concept is the combination of antivirals with immune stimulation. So for that type of combination, we can rely either on entry inhibitors, nucleoside analogs, capsid assembly modulators, and immune stimulation, for instance, of innate responses, interferon alpha or TLR agonist. Here we'll show you just a few examples. And the first one is very interesting because it's a combination of an entry inhibitor, bulevirtide, in combination with interferon that is developed for chronic hepatitis delta. But here I want to show you, to point your attention on the HBs antigen response with the 2 milligram bulevirtide dose in combination with interferon, which showed a 40% reduction of HBs antigen, more than a log decline, and even undetectability in some patients. So this is really interesting and needs to be kept in mind for future clinical trials for hepatitis B monoinfection. Other combinations include the combination of nukes with TLR8 agonist, elgantolimod, which showed a very nice safety profile and moderate decline in HBs antigen levels in the phase 2 clinical trials in E positive and E negative patients. So these results are encouraging and pave the way for future studies which may include a combination with other antiviral agents. Now, another interesting combination was the combination of tenofovir as a replication inhibitor, antigen reduction with a nucleic acid polymer, and immune stimulation with pegylated interferon alpha. And this was published very recently in Gastroenterology, and it showed that the nucleic acid polymer in combination with nuc and interferon can lead to a functional cure rate of 35%. So this is, again, also interesting and needs to be confirmed in larger studies. Now going to combination of inhibition of viral replication with stimulation of adaptive immune response. There was a nice proof of concept studies using tenofovir virus suppressed patients in combination with a checkpoint inhibitor, nivolumab, and a T-cell therapeutic vaccine. And in that trial that was published a couple of years ago, it was shown that a single dose administration of nivolumab at low dose in combination with tenofovir, with or without therapeutic vaccine, was able to induce a moderate decline in HBs antigen and was, more importantly, very safe in that type of combination. So this should pave the way for future study where multiple administration of checkpoint inhibitors and the therapeutic vaccine may be combined. It was interesting to see that one patient receiving nivolumab and tenofovir achieve HBs antigen loss. Now the next type of combination studies rely on the decreased expression of HBs antigen in combination with therapeutic vaccine. And this is based on the fact that high HBs antigen level are associated with T-cell exhaustion. And it was very elegantly demonstrated in a mouse model that mice that receive an siRNA to decrease viral antigen expression responded better to a therapeutic vaccine. So this may be evaluated in patients, since we have all the tools now. We have replication inhibitors, siRNAs, and therapeutic vaccine that could be evaluated in patients. Now, to finish, I want to really reiterate the fact that we have different class of drugs that we can combine. And really the challenge is to develop and design the best clinical trial to see whether combinations of replication inhibitors and antigen reduction can do the job for functional cure, or whether we will need to combine them with strategies to invigorate immune responses or immune stimulation to achieve HBs loss and a durable functional cure. With this, I would like to thank you for your attention.